Thanks for having me. I love these meetings, and I think the focus, you guys all know so much about what your condition is and who's managing it and everything else. This is sort of an overview, but it's also a focus on how far we as a community of families, treaters, paraprofessionals have come in terms of the recognition and the management of people with rare bleeding disorders. And I know sometimes it feels like you're the only one. So just to put it into context, right, the prevalence of von Willebrand disease is 1 in 100, with von Willebrand disease being the most common bleeding disorder, right, in the universe. So look at the difference in terms of the prevalence of this. Now, in the United States, the definition of a rare disorder is a disease or condition that affects fewer than 200,000 Americans, nothing like being egocentric. And in Europe, the European Commission on Public Health defines a rare disease as life-threatening or chronically debilitating diseases of such low prevalence that special combined efforts are needed to address them. I found that a little bit problematic to use that terminology, but again, it enhances the fact that people with rare disorders are unusual. So most bleeding disorders in general are considered rare disorders. Hemophilia A, Hemophilia B, and von Willebrand's disease together represent 80 to 85% of the inherited bleeding disorders. So it's a rare pool of people, but by the same token, most of them will have A, B, or von Willebrand's. The remaining 15%, I mean, it makes sense if these disorders are on different chromosomes, right? So it's not, it computes that you could have a mutation here, you could have a mutation here. Sometimes, which I'll talk about, is that it may not be one particular issue, because that contribution to your clotting abilities may be relatively small, but then you add another chromosomal defect. I mean, I'm almost at the point of saying, I'm not surprised if we find this and this together with this and this. I think it just hasn't been documented. And that's the name of the game, right? Okay. Platelet disorders, obviously, are rare bleeding disorders. That's in the other room. So this is something that I found to be really exciting. So in 1999, this is worldwide, this is through WFH, okay, there were a total of 78,629 people identified with the hemophilias. 1999, some of you are old enough to remember 1999. If you flash forward to 2018, there's a 3-fold increase in people who are identified. Similarly, von Willebrand's, even though it's the most common, again, you've got like a 3-fold increase. And in the rare bleeding disorders, you have a 7-fold increase in identification. And again, that's not everybody who's out there, right? But it just speaks to the fact that the rare bleeding disorders are a thing, okay? A thing worthy of paying attention to. It's not just, oh, there's just one. Oh, there's just one. We don't know what to do. There's a groundswell movement to make sure that we as treaters are working with our families to identify these disorders and also to bring people in so that we can be counted and accountable. And I think this is a huge change. Okay, now we're going to do this. Okay, so just a review, probably preaching to the choir here, but in my experience, you can't hear the basics enough. So if you all know it, wave your hand and I'll stop talking. When you talk about controlling bleeding, regardless of why you're bleeding, surgery, trauma, menstrual period, nose picking, whatever it is, 3 things happen all at the same time. And really, this happens in seconds. It's not nice and broken up. And the first thing that happens is that the blood vessel, which has been disrupted in some way, right? That's why you're bleeding somewhere. There's a torn blood vessel, tries to constrict on its own. And that actually starts to send out chemical signals to mobilize the rest of the team players here. The platelets, right, the little sticky pieces of cells are mobilized to move to that break in the lining of the blood vessel, and they adhere to the lining and they aggregate, they pump up onto each other. So at the end of that process, which is primary hemostasis, you have a glob. You have a glob of platelets with other stuff in there, but primarily platelets, and this is called a primary platelet plug. It's a Band-Aid. And it may or may not be enough to lessen or stop the bleeding. Usually doesn't stop it, but okay. But if you look at these platelet plugs under scanning electron microscopy, you see that there are gaps between these activated platelets. It looks like lace. And when I'm talking to families, I'm explaining that the platelets are like Velcro, and Velcro sticks. And then I've got the 4-year-old ripping his sneakers apart and showing me that, look, you have 2 pieces of Velcro and they have the little hairs and there's spaces between the hairs. And that's why you can rip it apart. Well, that's what your primary platelet plug is. You've got gaps. So if something doesn't happen to fill those gaps in, that platelet plug is going to eventually disintegrate. And it can disintegrate within an hour. So that maybe you thought, oh, it's getting a little bit better and I've applied pressure and I put ice, whatever I've done. But if you don't do something to solidify that clot, it's not going to work. This is where the fluid phase or the secondary phase of hemostasis comes into play. Okay, this is the activation of the clotting factors, what you know as the clotting cascade. It's predictable, it's orderly. We know a list, this to this, this to this, this to this. And in about, all told, 30 to 35 seconds, all the factors are working, they're doing their thing, and they make a biological glue or cement, which is called fibrin. And fibrin is the sticky stuff that fills in the gaps between those Velcro platelets and makes the clot tight. Now, you're very familiar with screening tests, right? Everybody here has had a PT and a PTT done. The PT, or the pro time, is very specific for gauging how long it takes for what's called the extrinsic pathway to work. This is the jump starter of coagulation. When you have your torn blood vessel, you have the exposure of tissue factor, right? It's torn. And tissue factor works with activated factor 7 to turn on factor 10. Factor 10 is a key player here. If you don't turn on factor 10, you're not going to make thrombin. So this is the jump start. And it's great. And it also explains why people who do have hemophilia, factor 11 deficiency, factor 12 deficiency, factor 9 deficiency, they do make a small amount of clot because there's nothing wrong in their factor 7 pathway. But it's really not very much. So flip over to the other side of this, and you have the intrinsic pathway, which is measured by the PTT. And that's where you've got your factor 12, your factor 11, factor 9, factor 8, all roads leading, of course, to factor 10, turning it on. This side presents what we call an amplification loop, and it augments what the factor 7 pathway has gotten started with. So you obviously need both of these in play and functional so that you can turn on factor 10 as much as you can turn on factor 10. And then factor 10 goes on to activating factor 5, factor 2, factor 1, which is fibrinogen. So this is the common pathway because all roads lead to that. And that's measured by your thrombin time. Now, it's not enough to say, oh, good, I've reached the end. It's taken me 32 seconds all told, and I've made fibrin, and now I have fibrin filling in the gaps between the platelets. That clot's still not particularly robust. It's better, but it's not robust. Why? Because fibrin, as it is produced here, is what we call a monomer. It's one molecule, right? I mean, it's obviously more than that, but it's just a solitary structure. Something has to be done to all of those fibrin molecules to make that clot tight. Enter factor 13. Who here has factor 13 deficiency? Okay. So here comes factor 13. And what factor 13 does is it cross-links those strands of fibrin and makes that clot tight. This happens outside of that clotting cascade. When I'm teaching residents, I say that factor 13 is the only factor which is not invited to play in the clotting cascade. It's got its own little place. And the consequence of that is that your PT, which can be anywhere from 9 to 14 seconds, depending on the lab, depending on the phase of the moon, depending on the reagents, or your PTT, which is, again, 29 to 34 seconds, all of that measures the time to fibrin monomer. So in a patient with factor 13 deficiency, their PT and their PTT are going to be normal. So you can have, and I'm sure some of you have these stories of having been diagnosed with factor 13 deficiency where people are scratching their heads because, well, I don't understand. The PT is normal. The PTT is normal. The platelet count is normal. And hey, I was there 30 years ago. That was me too saying that. So I'm not casting aspersions, but this is definitely where you need to start to think outside of the clotting cascade box. And you need to do specific tests for factor 13. Back in the day, we did clot solubility assays, and there were other things that we could do. Now we can actually measure for factor 13. But these are the broad strokes of that fluid phase. And you need all of these things in play and all of these things active. Okay. So this just gives you a graph, a pie chart of the frequency of the rare bleeding disorders. This is worldwide. This was based in 2018. And you can see of the rare deficiencies that factor 7 is the most frequently reported, followed by factor 11 deficiency and then the others. Okay. It's always critical to be able to talk when you are confronting a healthcare provider. Confronting is the wrong word. Having a discussion, meeting with, to make sure that if he or she is not asking the questions, give the answers that need to be counted. Who else in your family has, I don't know, nosebleeds, heavy periods, surgical bleeding, whatever? Give that up front if it's not going to be asked, because the history is so important in tracking back to try to identify where is the problem. The other thing, which may not be asked, is make sure that you provide the information of where your family is from. I always ask that, and I always have to say to patients, I don't want to hear that you're from Florida. I know you're from Florida. I want to know before that. I want to know where your parents are from, where your grandparents were from, because there are disorders which are more common in certain populations. And it's important to know that. The other question I always ask, it's a good icebreaker, is Mom and Dad, are you related? And that may open up a whole other can of worms. But again, we do know specifically for things like rare bleeding disorders, which are inherited usually as recessive traits, if parents are related, are cousins, first cousins for sure, even second cousins, you may get that mixture of genes which are common in the family, and bingo, you have a child who is more severely affected. I know in Palm Beach County, there is a high incidence of factor 7 deficiency. And there is a large population of Guatemalan Indians. And there is a tendency to marry cousins. So we've had a number of severely affected factor VII babies because of that consanguinity issue and that reality. So again, when you are meeting a physician for the first time, provide the information, even if they don't ask. And they don't ask. Yes, so once again, tag your it. Okay, and this is a surveillance, and this was done in 2010. So this just gives you a very small number of patients in general. I don't know how many of you remember the UDC at all, Universal Data Collection, which was something which was being done through the CDC, and it was trying to learn more about bleeding disorders. Again, more of the focus at that point was the hemophilias, but it was expanded. So this was just some data from, go back, come back. Okay, this was just some data of female patients with inherited bleeding disorders who were enrolled in the UDC. Not very many, 319. And this involved all the federally funded hemophilia programs in the United States. 300, that was what there was between 2009 and 2010. Now that's ancient history now, right? Right. That's participants in the study. That's the number of women who came to a federally funded hemophilia treatment center and who were identified as having a bleeding disorder and who consented to having their data shared with the UDC. It's small. So, you know, we've come a long way, right? We have a longer way to go, but we have come a long way. And what we've learned is that there is a higher prevalence in people of Eastern European Jewish extraction, right? Ashkenazi Jews. And certainly in South Florida, you've got Miami Beach, you've got Emerald Hills. But what is fascinating to me is I will always ask families, any possibility there's someone in your family who's from Eastern Europe and who's Jewish? Oh, no. Okay, no great grandmas floating around? And all of a sudden, I think then they're making the phone calls to, you know, whoever. All of a sudden it's like, well, you know, my husband's great grandmother came from Poland and we think maybe she could have been Jewish or one of her parents was Jewish. Bingo. And then we find it. So again, it's asking the questions. Mm-hmm. People aren't finding them. I mean, this factor 11, we'll go off topic here. Factor 11, with all due respect, is challenging. Why is it challenging? Because the percent activity as reported when you're measuring can be in the normal range, but people bleed. And years ago, I had a patient who was a leukemia patient, Jewish, and he was fine. I mean, he is fine now. He's like 40, which is weird, but he went through bone marrow, spinal taps, central venous access devices. He had an orthopedic complication. He went through all these surgeries, nothing. And then one day I had to cover him in clinic and he was due for some orthopedic thing. And I see his PTT is 50. I'm like, this is weird. I'm going back and sure enough, the kids had PTTs of 45 and 50 his whole life. Went ahead. And again, he wasn't my primary patient, so I feel vindicated. But I went back and I did his factor. I did the whole intrinsic pathway, and he had a factor 11 of 18%. And did the genetics. At that point, the genetics were not ATHN10, but could get the basic Ashkenazi Jewish mutation through Quest. And sure enough, he had one of the mutations. His sister, heavy periods, bruising, got her checked. Yes, she has the mutation, but her level was 78%. So this is again where genetics becomes so important outside of taking a history and paying attention, right? Because it's very squirrely. So these people, there are people out there, but like so much, everyone in my family does X. It's normal for us. And if you're not aware of the potential connection, perhaps with somebody from Eastern Europe.
Are you referring to genetic testing as far as like genetic counseling through the HTC Center? Or are you referring to like what is helpful just as an outside, like from an outside?
You can
doing like DNA 23andMe or?
I mean, listen, we have patients who come to us having done that, who have, or I've gotten referrals from patients who have been evaluated through one of these whole exome sequencing type things for another problem, usually an immunology problem or a neurological problem, and this binged up, and then they get sent to me. In general, things like factor 11, the basic mutations, can be ordered from Quest Labs or LabCorp.
No, I mean just in general, like if you have a bleeding disorder, you're saying it's helpful to have that information. So if I don't have that information.
Well, the question is, it's on an individual basis. I mean, we're talking about somebody coming in and we're shotgunning, right? You're getting all of that. I'm not saying that, no, if you don't, the world doesn't need to be tested for factor 11 deficiency. I mean, but in terms of doing genetics, if you have an established diagnosis already, then you're hooked in with the center, then you have an established diagnosis, and sometimes it needs to be refined, as was in your case when things just didn't add up, right? And then you start working the network that you've got, because no one person is going to know everything, that's for sure. I think one thing which is really special about the bleeding disorders community is that we are pretty much of the mindset that it takes a village. And we all kind of know who to call when we're scratching our heads. So I think I think it's important for the patients and the families to understand that we all do talk to each other. Well, I mean, no. I mean, in terms of, this is confusing. I have a patient whose symptoms don't match up with something. What do you think? I mean, we're constantly reaching out, and we are being reached out to for our experiences from other healthcare providers. You know, I mean, I think that while I'm very used to that from the group of pediatricians who routinely sends referrals to our division, it's really true in terms of other treaters in the bleeding disorders community. I mean, we really, I mean, look, you're always going to get somebody, right, who's not quite on that page, but in general, people are very willing to share experiences because it's all for moving things forward. And we see very clearly where we were and where we are as a treating community, as a community of families. It's a very big night and day difference. I started our program in 1987. I was 5. It was amazing. I was so precocious that it was absolutely amazing. My mother said so all the time. But it is night and day different in terms of how we talk with our families, and no longer having the professional stigma of having to ask a question. I mean, there was a real good old, no offense to the gentleman in the room, a real set of good old boys clubs, all right, where, you know, you couldn't ask for help. You were supposed to know everything the minute you passed your boards, type of stuff. And it's, that goes without saying. Again, my apologies, gentlemen, if you have a Y chromosome. But the reality is that this is a community. Now, you may have to do a number of phone calls, but you'll find somebody. And if you've got a concern, be a squeaky wheel and work with organizations like CHESS, and you may find paths that you weren't aware of, as you're saying, yes. So just again, looking at where we were, where we are, take a look at this, because this is from the Athens database from September 2010 to December 31st, 2017. There were 8,820 women reported in the database. So things have changed, right? And again, predictably, 63% of the female participants turned out to have von Willebrand's disease. And then the second most common were platelet disorders, but you still had 764 women enrolled through Athens at 2017 with a rare factor deficiency. So, and we're past that now, right? We're 2024. And I'm sure that we can speak to even more at this point. So what's the problem here? Okay. And the problem for rare bleeding disorders in general, there is a delay in diagnosis. And there's a delay in diagnosis in general for women. There's an excellent article, if you are into reading articles, by Angela Wayand, called Sexism in the Bleeding Disorders, right? But you know, it's a validation. It's out there. It's a wonderful article with a lot of common sense things. We did a study where we were looking at girls who came into our ER, our clinic with heavy periods, iron deficiency, syncopal episodes, whatever. And retrospective, and found that there were about 100 girls menstruating females who came in with this. And of those, 50 had a bleeding disorder. And of those 50, half of them had factor VII deficiency. So the information is there, but if you look at the delay in diagnosis from onset of symptoms for guys, and again, we're looking primarily the hemophilias, right? You can pick up a severe hemophiliac within the first couple of months of life. Moderates, even to under a year of age. Milds may take a little bit longer. Women can have a delay of years and years of managing and dealing until somebody connects the dots or a new dot is presented. So that's a huge, huge, huge problem, right? There's always, what are we going to do to treat it? I mean, and this is where development has also lagged somewhat. Why? Because you can't just mix something up in your kitchen and give it to somebody. I mean, you can, but they tend to not like that. You need to do this in an organized way. You need to have the laboratory or the bench experience to be able to say, I think this is going to work. And if you're dealing with a small number of patients, money talks. Is that economically practical use of resources for industry, for clinics? So therein is also a problem. We got to figure out what's out there. How many people can we offer something which is going to be beneficial, but how are we going to prove it? Then you run into the problem with insurance companies. Anybody have problems with insurance company? Only you too? Oh my God, I feel like I'm in utopia here. Because again, it's a question of reimbursement. And this has gotten worse and worse and worse. Whether it's reimbursement to be seen at a center, whether it's reimbursement to get a particular product. So therein can be months to years of delay as well. So one of the questions that we as a treating community and also as a research community need to answer is, how many people do you need to have a valid study? And if you've got only 500 people with a particularly identified disorder, is that economically feasible? That's where things like these meetings, things like empowering you all, things like the Athens 10 come into play, because it's going to grow the ranks of the numbers and it's going to make, hopefully, things move a little faster. The other thing is that we need to get more women into clinical trials. I mean, that just goes without saying. Since we've moved the needle to a certain extent away from the hemophilias, certainly von Willebrand's is got a lot of people with that, but we need to get more women to come in for it. And we know that women are busier. We know that there are multiple demands on our time, but somehow, and again, this is an area where perhaps organizations like you guys can come up with ideas. What might it take to be able to have more women come in for? Well, yes, that's number one. But even so, what can be done for a convenience factor? Should studies be built in such a way that maybe there's more mobile centers, right? So that it's not you having to drive 4 hours on the day that your kid has soccer practice. And oh, by the way, you have this and, it's Halloween or, whatever it is, to be able to come into a center. And these are the ideas that we are looking for from the people who have boots on the ground. And again, genetics, this is really simple, but rare bleeding disorders affect both male and female. They are usually autosomal recessive. Remember that the hemophilias are what we call X-linked, right? The gene is found for factor VIII, factor IX is found on the X chromosome. These are sex-linked. But what we are finding, and what we saw so clearly with our little bleeding disorder study that we did, is that the number may not matter. Yes, less than 1% of anything, you're going to have a problem. That goes without saying. But you know what? You can have, if you've got the mutation, and this is where our heads are moving towards, if you've got the mutation and you're bleeding and there's nothing else, it doesn't matter if your number is over the magical 50%. You don't need to have 50 to 150% of anything all the time to be functional. And maybe you do. We're learning in von Willebrands, there's now this category of low von Willebrand factor. These were all of these women and men that were scratching our heads because they're bleeding, but they've got a 49% or a 51% level. Oh, well, it just can't be. And we're learning that it can be. It is. Whether that involves other genes that are involved in the process of making a protein, I think that that's under investigation. But again, it's not necessarily the number. And when Dr. Sims talks about periods, this plays right into it. If somebody says their period's too heavy, it's too heavy. It doesn't matter what you think. Sorry, guys. But, I mean, you have to look at the big picture, right? And that's very difficult for practitioners who were very number focused. And we're very number focused as a society, right? That's why we have SATs and all of this stuff, because numbers are the great equalizer. Well, we're learning that they're not. You got to look at the bigger picture. There are no racial or ethnic differences. Yes, if you have a consanguineous population, you are going to have more severity showing up. But again, this is if you have two parents who are carriers, meaning that they have one normal gene for fill in the blank and one mutated gene. Well, 1 out of 4 of their children technically are going to be severely affected. That's a little guy on the left in red. 1 out of 4 technically will get, or every pregnancy, 1 out of 4 chances of getting the 2 normal genes, and then you have the others that are carriers. Okay. I would also raise a question. A gazillion years ago, women with hemophilia who were carrying the gene were carriers, period, end of sentence. It didn't matter what their levels were. It really didn't matter. But insurance companies were not paying for healthcare because carriers don't have problems because it's just there. So again, it's an education curve. It's changing the vocabulary and the way that we're starting to report things are heterozygous for factor VII deficiency. What does that mean? Oh, it means you only have one gene. Oh, you're a carrier. But if you say heterozygous, all of a sudden people are willing to potentially get you what you need. Okay, and this just shows you the variety of what we call the autosomes, the non-sex chromosomes, where these different genes are found. And yes, there are some chromosomes that actually carry the genes for 2 different disorders. They're not next to each other. They're not, they're not related that way, but they just happen to be on the same chromosome. So again, this just gives you an idea of the gamut of the chromosomes that are involved. And again, there's a variable association between the number and what's going on. It just is. Again, a question of how symptomatic are people. Certainly you can see that many, the majority don't have, majority meaning over 50%, don't have symptoms. And again, it depends on how the questions are asked. How many of you are familiar with bleeding assessment tools? How many of you have a bat? They're bats. How many of you have a bat done when you go to clinic? Okay. I mean, there are a million of these bleeding assessment tools out there, right? I mean, it's definitely something which can be very helpful because, again, it puts a number, it puts a quantification on this amorphous symptomatology. And it's definitely something that when we talk to girls, to moms about their periods, I love doing this to trainees. How's her period? Oh, it's fine. Really? What did you ask? I asked her how her period was. She said it's fine. Okay. Let's start asking more targeted questions, and you'll hear a lot more from Judy about that. But you really have to ask the questions. And that's where these bleeding assessment tools come into play. You can either have very elaborate ones, which will take you forever, which means that's why people aren't doing it in clinic, because it takes forever. But, you know, let's refine what your symptom is, a nosebleed. Okay, how old were you or your child when he or she developed a nosebleed? Red flag, trivia point, nosebleeds under the age of 2 are not normal.
Yeah.
If you've got a kid who's got nosebleed, or you started your nosebleeds at a year of age, 18 months of age, unless you happen to keep falling on the playground and bopping your nose, that's not normal. That needs to be investigated. So again, it's very specific questioning that needs to be asked. There are self-bats which are out there, and you can Google them. And what those are actually very helpful. They're not very specific. It's asking general questions and you're answering yes or no. And at the end of it, which takes about 3 minutes, 4 minutes, you get a score, but it says, based on your answers, it is not likely that you have a bleeding disorder, or based on your answers, you should be evaluated for a possible bleeding disorder. And I have found, just in a limited, you know, like sitting around with friends, hey, why don't you take this? It's easy to do. And at least we are trying to incorporate this into clinics so that when we have the girls coming in or the guys coming in and they're all sitting on their phones waiting for everybody anyway, hey, why don't you do this? So that when we walk in, at least we can say, what did it show? And what that does, first of all, it's helpful, right? It's helpful for us, but it also may help to validate what your kid's experience has been. Because this is something in black and white or blue and white or whatever your phone is. But it's something tangible. And it's not just asking these open-ended questions. So talking about factor 11 deficiency, if you've got a level below 20%, in general, you're more likely to have bleeding complications. Common bleeding problems are bruising, epistaxis, bloody urine hematuria, menorrhagia, which is now called heavy menstrual bleeding, and hematomas, or big lumpy bruises. You get increased bleeding where there is increased fibrinolytic activity, meaning the whole thing with the clotting cascade, it's a balance. It's the clot forming and the clot busting systems. So we don't want clots to stick around too much, right? That's a bad thing also. So the instant that you're making a clot, the clot busting system or the fibrinolytic system comes into play. So this is really a dance and it's a balance. But there are places in our systems which are very active fibrinolytic sites. And those are the mouth, in particular, the nose, the mouth, the GI tract. So in patients with factor 11 deficiency, whose clot may not be particularly robust, for some reason, and again, we don't know the genetics. We don't know what's upstream and what's downstream and we don't have that yet. But people with factor 11 deficiency, and also people with factor VII deficiency. If you've got an injury or a bleed in one of these areas, you are more likely to bleed heavily. We are very meticulous when it comes to wisdom teeth extractions, when it comes to tonsillectomies, sinus surgery, adenoidectomies. I'm a little bit nuts about colonoscopies and endoscopies because that's just me, but getting them and being safe for them, yes. Probably not. Yeah. I mean, again, this is conversations as well, because yes, if you've got a scoping and there's going to be biopsies done in particular, you want to have at least an antifibrinolytic on board, at least that. Spontaneous bleeding is rare in factor 11s. Postpartum bleeding is a real issue. Hemarthroses or joint bleeds are really not a feature. And this just reiterates the great grandma. Okay. Afibrinogenemia, hypofibrinogenemia, dysfibrinogenemia. Fibrinogen is that last stage of cleavage with thrombin to fibrin. People can be born with the inability to make fibrinogen. They can be born with the ability to make a lot, but it don't work right. They can make a less than normal amount of a structurally normal protein. And all of these different things, again, come into play in terms of trying to predict whether or not somebody either has it or how severely they're affected, or do they have it. And again, genetics is a big deal here as well. Yes. Yes, this is factor 1. Sorry. Yes. Okay. Glanzmann's is being talked about there. Okay. So what's the frequency of bleeding in women with bleeding disorders? The big deal with women is always reproductive bleeding, periods and pregnancy postpartum. Okay. 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 All right. Thank you, Judy. Okay. All right. So again, reproductive bleeding is right up there, and is probably heavy menstrual bleeding or menorrhagia is probably the highest incident across the diagnostic spectrum. There are very definite parameters. And this again just shows you across a diagnostic spectrum the percent of women who were surveyed in terms of what they had in terms of a hematological diagnosis and how they realized that heavy menstrual bleeding was a thing. It's huge. It's just huge. And you've all been with providers who say, you're a woman. Of course you have heavy periods. Of course you have iron deficiency. Okay. Mm-hmm. And again, I mean, I've heard such stories about, oh, it's normal for us. We sit on towels for 7 days a month. I can't wear, I'm from Florida, right? I can't wear white shorts. I can't go swimming with my friends. I can't, but it's normal for us. Why am I bothering? And in the medical community has changed. I think there's a little bit more listening, or maybe it's a more litigious environment, but people are getting more screenings. Going along with the heavy periods, obviously anemia and iron deficiency kind of go hand in hand. And as one of the participants said, fixing your low iron can fix a lot of things. I mean, we don't really appreciate living in real time how much iron does beyond raising your hemoglobin level, right? So again, very, very important. And that is one of the questions that we always ask when we're doing a family history or a personal history, which is, have you ever been told you have low iron? Have you ever been treated for low iron? Has your mother ever been treated for low iron? Any women in your family on either side who have been recommended or received a blood transfusion as management of either heavy menstrual bleeding or low iron, a hysterectomy, an endometrial ablation. Again, this is information which is important to be able to share with your healthcare provider. And some of you are participating in our women's ultrasound project. This is old data. We've been doing this for a while. Certainly building on the realities of the hemophilias, right, where the hallmark of hemophilic bleeding is joint bleeding. And there was a study done in 2007, which was a very important seminal study called the Joint Outcome Study, where Dr. DeManco Johnson from Denver at the time was looking at boys with toddler boys up through age 6 with severe hemophilia, looking to see how different interventions, prophylaxis versus on demand, did it make a difference? Well, one of the things that came out of that study was the fact that you could have kids who were very adherent to what was being prescribed. Perfect joints, pristine joints, physical therapy, everything is great, but they built in MRIs because this was a study, and they saw changes on MRI consistent with having had joint bleeds. Thus is born the concept of the subclinical or microbleed. So building on that, we developed a study looking at carrier women for the hemophilias, and then took it to the next level. And you guys are going to be the last of this study for those of you who are participating, because there's always an endpoint when the money runs out. But why is it possible that women with other diagnosed bleeding disorders can have even subclinical joint bleeds? Doesn't have to be an overt joint bleed. And the musculoskeletal ultrasound is very good at picking up some of these changes. I mean, it would be nice to get MRIs on everybody, but that wouldn't be able to go on carry-on the plane. So that's the purpose of this study for those of you who signed up. And we're limiting it between 18 and 50. First of all, if you're very young, you're growing, it's hard to reconcile some of the changes. If you're over a certain age, it's also hard to necessarily correlate what could be just normal age-related changes. But I know that there's about 7 or 8 of you who have signed up. I know we've done probably 2 by now, and a few more this afternoon, and we appreciate it. Because by the end of the day, when all is wrapped up, we will have information, at least probably around 30 women all told, with bleeding disorders other than being carrier for hemophilia.